me. My name's Ryan, and today I'll be talking a bit about the mitral valve. So we'll cover some normal anatomy, we'll talk about prolapse, then we'll talk about mitral annular disjunction, and a couple other things thrown in there. There we go. So no disclosures as of yet. Objectives-wise, so we're going to talk about the normal anatomy of the mitral valve. We're going to review causes and appearance of a myxomatous degradation of the mitral valve. We'll talk about the definition of mitral valve prolapse, what causes it, some of its echocardiographic criteria for diagnosis, and some potential complications. We'll define mitral annular disjunction and review its appearance on echo, and also talk about its potential complications. And so to start off with a little bit of history, so first in 1887 was the first time that a systolic murmur with a mid-systolic click was described. And then almost 100 years later, in 1963, Barlow, pictured here, demonstrated that these findings were due to mitral regurgitation, and he found that via LV cine angiography. And this is when it was quoted Barlow's disease. He thought that this click was secondary to rheumatic mitral disease, and that's what was causing the mitral regurgitation. Then just a couple years later, in 1966, this hypothesis was corrected, and they determined that this mid-systolic click heard on auscultation was actually due to excessive posterior leaflet motion into the left atrium, or what we know today as mitral valve prolapse. The first ever case of mitral valve prolapse was actually in 1970, and it was done by a group at Toronto General. That was the first publication of it. They showed that there was prolapse of the posterior leaflet of the mitral valve into the left atrium on angiography, and this is the figure that they published here. They then went on to show that there was a thickened posterior mitral valve leaflet, which was seen intraoperatively. And then they determined that the cause of Barlow's disease was a diffuse thickening of the leaflets with elongation of the cord and myxomatous degeneration. So that was then further refined by Carpentier, who published his Carpentier classification, which is classification of mitral disease. And this was in a 10-year appraisal of mitral valve incompetence. And he confirmed some of the aspects of Barlow's disease by surgical exploration. So intraoperatively, they found that there was significant myxomatous degeneration of the mitral valve, and they could see the prolapse of the valve leaflets. But also identified another type of mitral valve prolapse where it didn't have this same redundant leaf tissue. So there wasn't the same myxomatous degeneration. And this prolapse, they believed, was primarily due to chordal rupture, and they found that the cords and leaflets were very thin. And this was called fibroelastic deficiency, and something we still refer to today. And you can see some of, in the bottom images here, some of the sections of what the actual pathology looks like. So with a lot of, and I'll talk about this again in a minute, but a lot of increased collagen and elastin in the myxomatous tissue. So on to mitral valve prolapse very briefly. So what is it? It's a systolic billowing and or flail of one or both mitral leaflets into the left atrium that occurs during ventricular systole. And it's quite prevalent. So we see it in about 1 to 2.5 of the entire population. I'm sure all of you guys see it probably close to once a day, at least in the echo lab. And I think reading, we've come across it quite frequently. So it's quite common that we see here. So in order to properly talk about mitral valve prolapse, we need to first just review some of the anatomy. So a normal mitral valve consists of two mitral leaflets. There's the anterior and the posterior leaflet, the saddle-shaped annulus, the subvalvular apparatus, which includes the cords and the pap muscles, the ventricular wall, and the left atrium. And to go a little bit more specific, there's several leaflets. So there's the posterior leaflet, which is quadrangular and shaped and divided into 3 different segments. So P1 is the most anterolateral portion of the leaflet, and it's closest to the left atrial appendage. Then P3 is closest to the tricuspid annulus and the right ventricle, and P2 is situated in tidal. And the anterior leaflets correspond to the posterior leaflets, and they're A1, A2, and A3. But the anatomical markings are typically based off of the posterior leaflets. So looking at what this looks like on transthoracic, so this is just a parasternal long view of the mitral valve. And on the left image in A, we see it in systole, so where the leaflets are closed, you can barely see the cords. You have the anterior and posterior mitral valve leaflets. And in diastole, we see here, again, the opening of the mitral valve leaflets and the anterior valve close to the aorta, or anterior leaflet close to the aortic valve, and posterior leaflet at the base here. And then again, more specifically, looking at a couple different views, some of the views that we can see the different aspects of the mitral valve leaflet, which becomes important when we start talking about prolapse. So in the top left here is a parasternal lung where we can see the A2 and P2 segments. On the short axis, we can see all 6 segments of the mitral valve leaflets. In the apical 4, we typically can see P1 from the posterior side and A2 and A3. And on the apical 2, we get P1 with P3 and A2 in the middle. So this is helpful when we're looking at prolapse and trying to get an idea of which specific segment of the leaflet is prolapsing. So then M mode also becomes quite important when looking at mitral valve prolapse. So here you can see kind of a couple segments, one a tracing of M mode on the left and an actual M mode on the right, and this is in just a normal. So just orienting ourselves here, D is the closure of the mitral valve leaflets. It's the initiation of the beginning of diastole. E is the peak anterior excursion of the mitral valve leaflet from the midline when there's rapid filling of the left ventricle. Then as the chambers equilibrate, the mitral valve leaflet starts to close slightly, and that's how we get F. And then with atrial systole or atrial kick, we get a slight opening of the mitral valve leaflets again, and we see another peak here in A. And lastly, just showing what the normal closure of the mitral valve leaflets. So we know that normally there's a coaptation zone where we see a couple millimeters of the leaflets closing. They don't close at their tips, and they close together, usually around a 4 millimeter length called the zona coapta. And it looks something like this when it's closed. Okay, so myxomatous disease or myxomatous mitral valve. So it's one of the most common forms of valvular heart disease in about 0.6 to 2.4% of the population. It's characterized by abnormal tissue architecture. So we can see here a normal valve on the left, and these are pathological segments, and a myxomatous valve on the right. We can see that there's increases in the layer of collagen. So there's a much thicker layer of collagen here than there is just right here. There's an increase in the spongiosa layer. There's lots of proteoglycans, so in the middle layer here, and so this is much thicker than the one on the normal valve. And we can also see that there's a slight increase in the amount of elastin, but it also gets disrupted. So you can kind of see that it's very thin segments kind of running along, and here it's a little bit thicker and sometimes can be a little bit fibrosed. And then the bottom images here are just showing the difference in the thickness. So over double the thickness, typically myxomatous valves compared to normal valves on average, and much higher density of cells, which is also what we see pathologically. And there's lots of different associations of myxomatous mitral valve disease with other diseases. The first two, obviously, that we'll talk about today is mitral valve prolapse and mitral annular disjunction. But we also see dilation of the mitral annulus. We can get arrhythmic mitral valve prolapse, which we'll touch on a little bit later. Significant LV remodeling just associated with myxomatous disease. And there's multiple different causes. And so the causes can go from kind of primary myxomatous disease, which includes genetic or familial inheritance, and that's the majority of what we see. But also there's a lot secondary to connective tissue disease, like Marfan, Ehlers-Danlos, Loeys-Dietz, which are some of the aortic syndromes. So as I said, there's two primary types of mitral valve prolapse, and then there's a whole list of different syndromic causes, which are some of the ones secondary to the connective tissue disease. The two primary ones, which I mentioned briefly earlier, but we'll go into a little bit more detail on now, are myxomatous disease. So the myxomatous disease typically has two different inheritance patterns. It can either be X-linked or autosomal dominant, but exactly how it's inherited, we still don't quite know yet. So they're still fairly relatively early on in that research. Or it can be fibroelastic deficiency. And usually that's secondary to connective tissue disease, but it can also come on its own. And so of the two types, the Barlow's disease, or the one associated with myxomatous mitral valve disease, we typically see the billowing of the mitral valve. And as we've said, it's associated with excess tissue with free edge prolapse, which presents with a mid to late systolic click, whereas fibroelastic deficiency more often occurs with a flail leaflet. And so we often see a flail leaflet on echo as opposed to just the prolapsing leaflet that's still collapsed. And it's usually due to a rupture of a cord or a pap muscle. And then a little bit more specifically on those two, so what we see clinically and what the patients look like. So patients with Barlow's disease, they have the degenerative myxomatous valve. They get diffuse thickening of the leaflets, and this leads to billowing of often one segment of the valve, often multiple segments or multiple leaflets. It's typically common in younger patients, so it usually first presents in their 30s to 40s. They're usually asymptomatic. However, usually clinically, they've had a murmur for most of their life. On M mode, we can see that there's usually a large thickened valve greater than 3 millimeters, and it's frequently accompanied by myxomatous changes of the tricuspid valve as well. Whereas in fibroelastic deficiency, this is usually from a deficiency in connective tissue that leads to thinning of the mitral leaflets and cord rupture or flail. Patients are typically older. They're usually asymptomatic until the cord ruptures, and then they start to become asymptomatic from the accompanying mitral regurgitation. They usually do not have a murmur for the majority of their life, again, until the cord ruptures, and then they start to develop a murmur. And in this fibroelastic deficiency, it's typically the P2 segment of the leaflet that's affected. And again, this is just a chart that's summarizing some of the same thing. Again, the ages, typically younger age in Barlow's deficiency, usually older in fibroelastic deficiency because it's not until the symptoms present. As we said on auscultation, you usually get a mid-systolic click or a late systolic murmur in Barlow's disease, so that's more of our classic mitral valve prolapse. Whereas in fibroelastic deficiency, they usually have holosystolic murmur because their leaflet is completely prolapsed and flail. And then surgically, we've talked a little bit about what that already looks like, but from a repair standpoint, Barlow's disease is typically much more difficult to repair than just a flail leaflet, which they can easily repair surgically. Okay, so how do we assess mitral valve prolapse on echo? There's multiple different criteria. M mode is quite helpful, and M mode is actually very, very specific. So there's two primary criteria on M mode. The first being greater than 3 millimeters of late systolic buckling, or pansystolic hammoking of 5 millimeters or more, and I'll show you a couple images of that in a second. But there was a study in the 80s that looked at multiple different ways of looking on M mode for mitral valve prolapse and their sensitivity and specificity. And pretty much all of them are quite specific, like the late systolic posterior motion or the buckling of the valve on M mode has like 100% specificity and 57% sensitivity. The hammocking is very similar with 99% specificity, but it's not quite as sensitive. But when you combine the two criteria together, if both are present, it's very specific and very sensitive. So M mode is actually quite good for detecting mitral valve prolapse. Otherwise, when looking, we usually tend to look in the parasternal long axis. We see displacement of the mitral leaflets beyond the level of the mitral annulus into the left atrium. And we need to see 2 millimeters of displacement relative to the annulus in at least one or more segments. The apical views are sometimes tricky. In the apical four-chamber, we shouldn't typically use that view to assess for mitral valve prolapse because you can give a false diagnosis because of the plane of the annulus that we see in that view. However, sometimes you can use the apical three-chamber view. It's a little bit more similar to the parasternal long. The problem, as we said earlier, is the parasternal long, you only really have access to the A2 and P2 segments. So if you have flail or prolapse of some of the other segments of the mitral valve, you're not always going to see them. And so seeing them in either parasternal short or with sometimes on the apicals, if it's very, very obvious and large, you can see them, or by TEE if not. And so here's a couple examples of M mode. So I've just put the normal M mode on the left here for comparison. But here's an example of a patient that has mitral valve prolapse, and we can very clearly see here where the white arrows are the late systolic buckling, and that lasts for at least 3 millimeters. So that is one of the criteria. The hammocking will be better shown in another one. So this is one of our patients that I came across the other day. And again, we see the kind of late systolic buckling pattern here. And we can see basically throughout all of diastole, there's this kind of like hammocking pattern that we see also in the posterior part here. And that lasts for almost all of diastole, which is going to be more than 5 millimeters on the strip there. So with both of them being present, we have quite high specificity. And then a couple clips, which hopefully will play here. Maybe a little bit on the lag side. Does anyone want to maybe comment on what we see in kind of the clips here? And the same clip, just one without and one with color. They're playing nicely on my computer, but they're freezing a bit on the screen. But I think we can still make out what we have. Yeah, so we can see quite clear prolapse. we can see quite severe or moderate to severe mitral regurgitation when we put color over it. And it's freezing, so we can't actually totally see it, but it's actually prolapse of both leaflets. You can see when we freeze the screen here and draw a line between, have it here, but it's kind of cover here. I believe like the length here was around 10 millimeters, and this is around 4. So we have significant prolapse in both the anterior and the posterior mitral valve leaflet. So this is one way that we can check for it, obviously, is freezing the image and measuring our distances. And again, we're looking for more than 2 millimeters to diagnose someone with prolapse. This is another image here that's an example of just posterior leaflet mitral valve prolapse in the parasternal long. So we see the anterior leaflet up here looks just fine. It's not breaking the plane of the mitral annulus, but the posterior leaflet is slightly here. And so we can say that there's posterior leaflet prolapse. On 3D reconstruction, sometimes you can see these quite well as well. So we have an example of normal on the left here, where we see all of the segments of the mitral valve and the mitral valve leaflets in fibroelastic deficiency, where there's a flail of the P2 segment here, and in Barlow's disease, where we can see there's pretty significant thickening of the valve kind of all around, and we have the myxomatous changes. This is another figure showing an example of some different types of prolapse. On the left, we have a patient with Barlow's disease. So with the typical mitral valve prolapse, thickening of the mitral valve leaflets. They're thick, they're bulky, they're billowing into the left atrium. I believe this one is a transgastric view from TEE. But if we were to draw a line across the mitral valve annulus, you could clearly see that there's at least 2 millimeters of prolapse in both leaflets. And then over here, where we have a different example, this would be more consistent with like a fibroelastic deficiency, where you get prolapse of primarily the P3 leaflet, but a significant amount of the whole posterior leaflet as well, which can be seen up here. And we have a ruptured cord probably that's causing that, and that's an example of fibroelastic deficiency. We can see on the leaflets themselves, the leaflets are very thin, compared to over on the myxomatous valve, where the leaflets are quite thick. And this prolapse is secondary to a ruptured cord as opposed to just billowing of the valve. This is again just comparing what they look like on transthoracic as well as a 3D reconstruction on transesophageal. So we have an example of Barlow's here with thickened leaflets and prolapse of both leaflets. And we can see that it looks quite bulky on the 3D reconstruction, thickening of the valve. Whereas in this segment where we have an example of a flail, we can see the same thing kind of in the P2 segment here, it's flailed. Comparison up here on the transthoracic. And this video, unfortunately, was a little bit, a couple of the next videos were a little bit short and cut off because of some issues with converting them to MP4. Does anyone want to take a stab at what this one is here? The type of prolapse. So we see the anterior leaflet for the most part looks pretty good. The anterior leaflet here is not prolapsing. It doesn't cross the line of the mitral annulus, but the posterior leaflet is prolapsing. So this is just an example of isolated posterior leaflet prolapse. Again, based on the view that we're on, it's most likely P2. We can't say for sure because we can't see all of the other elements of the posterior mitral valve leaflet super well here, but we can say that there's definitely an element of P2 prolapse here. And this is a transthoracic and transesophageal of the same patient. Again, sorry, the clips are a little bit truncated here, but anyone want to have a shot with what we see here? Okay, yeah. So we see again, anterior leaflet for the most part looks okay. We see a flail portion of the posterior leaflet, and we can see it very clearly here at the flail of the posterior leaflet on transesophageal. Okay, so from that, we'll take a little bit of a pivot. There's a lot of stuff about mitral valve prolapse. We'll talk a little bit about mitral annular disjunction. So first to start off, what is it? So it's an abnormal insertion of the hinge line of the posterior mitral leaflet in the atrial wall. And it results in a separation, or it's disjunct, hence the name, from the crest of the left ventricular myocardium. And it was actually first described in 1981, but has been becoming a lot more popular, especially in the last 5 years, with some of the consequences, which we'll talk about. Its definition exactly is a dislocation of the hinge line of the posterior leaflet of the posterior wall of the left atrium away from the crest of the left ventricular wall in the direction of the roof of the left atrium. It's very frequently associated with mitral valve prolapse, and I know we think about it a lot is that mitral annular disjunction comes with mitral valve prolapse. And depending on which study you look at, it's in roughly 30 to 60% of patients with mitral valve prolapse. But as we'll talk about, it can be also seen not infrequently in patients who do not have mitral valve prolapse, so just as an isolated entity on its own. So a couple figures kind of here, just what it looks like. So there's a couple different theories as to why mitral annular disjunction occurs in mitral valve prolapse. No one exactly knows why. There's kind of a sliding theory and there's a stretched theory. So the first example at the top here is an example of a slid annulus, or the sliding theory. So just to orient ourselves, if this is the atrial wall and this is the posterior leaflet of the mitral valve, the ventricular myocardium, our hinge point is typically, as we said, right at the top of the ventricular myocardium in the left atrial wall. Now, if that point moves, then that's when we get mitral annular disjunction. So one theory is that this point actually slides and that there's something here, some sort of tissue, fibrosis, cartilage, etc., but the hinge point actually slides away, which we can see here. So sliding of the annulus up towards the left atrium, and this being separated by something. Or another potential theory is that there's actually stretching of the annulus. So the annulus itself gets stretched out, which again may have its consequences over time, which we'll discuss. And it's that leads to the displacement of the mitral annulus from the tip of the ventricular myocardium. So where do we look for it? Well, mitral annular disjunction is a systolic criteria, so we typically only want to look for it in systole, because in diastole, the myocardium is very relaxed, so the posterior annulus, or the hinge point of the posterior leaflet, appears to be sitting normally on the ventricular myocardium. So you wouldn't typically see any changes in diastole, but in systole, as the myocardium contracts, the hinge line can slide, and then you get your visibility of the mitral annular disjunction. So it actually can become variably detached from the ventricular myocardium, and I'll show lots of different pictures to try and help make that more clear. How we measure it, it's quite hard to do on echo. It is possible. You'll see some images and you'll see the difference in clarity between echo and MRI. But we measure it as the distance from the left atrial wall and mitral valve leaflet junction to the top of the left ventricle. And again, this is during end systole and typically in the parasternal long axis. And it's defined as the longitudinal distance of the disjunction in the posterolateral wall. On cardiac MRI, it's similar, where we measure the distance from the left atrial wall to the mitral valve leaflet junction to the top of the LV wall, again during end systole, but it's obviously going to be in a different sequence because it's on MRI. And it's typically present if it's greater than 1 millimeter. As you'll see, it's much, much easier to see on CMR. So this is an image that actually comes from a great paper kind of summarizing mitral annular disjunction just very recently in early August 2023, and it was presented at ESC. But we can see here very clearly an example of normal in the top left. So this is just a normal echo. There's no prolapse. The mitral annulus is right here. Compared to what we see on the right is a patient who has mitral valve prolapse. There's greater than 2 millimeters of prolapse, again, in the parasternal long, but the mitral annulus seems to be here at the end systole. And obviously this is just a photo, so we have to kind of take our word based off of the photo, but we'll see it in some videos. This is an example in those kind of same patients that have the mitral valve prolapse where we see disjunction. So at end diastole, we see that the mitral valve annulus would be here, and at the end of systole, the annulus becomes here. So it's posteriorly moving towards the left atrium, and we can measure the distance in which it moves, and that's our mitral annular disjunction distance. And again, it's present if it's more than 1 millimeter, although quite hard to measure on echo. Just another example looking in a couple of different views where you can also sometimes see it. Also sometimes there's examples of it in different areas of the atrium as well, because of course it could be anywhere along the mitral annulus. In this example, we see that there's about 15 millimeters, so the annulus, which normally would actually be placed somewhere around here, is displaced into the left atrium. And again, we can measure it on multiple different views, parasternal long or apical long, where you would see the displacement of the mitral annular disjunction. And we'll see what that looks like a little bit better in a second on some videos. There's also a concept of pseudomad. So sometimes we think that there's mitral annular disjunction, but it's actually just because the mitral valve leaflet is so curled that it's so curled up into the left atrium because there's such significant prolapse that it looks like the annulus has moved. But actually the leaflet is all there and coming from the same point on the annular junction, but it's just a curvature of the leaflet that makes it look like it. So we can see here, for example, if this is the mitral annulus and our mitral valve leaflet prolapses so significantly that part of the leaflet is up against the inner part of the atrial wall, then we might think that this is the mitral annulus right here, and that there's disjunction of whatever this distance would be, when in fact the mitral leaflet is just hugging the wall there and the annulus is still staying in the same spot. So that's sometimes that can occasionally happen. Again, on echo, it would be very hard to pick up the differences in what these structures would look like. Sometimes you can see it, especially if there's a tiny little bit of a gap between them, but it becomes much more obvious on cardiac MRI. And so here's an example from both echo and cardiac MRI of regular pseudomad and true mad. So again, these are images from CMR. We can very clearly see the mitral annulus where the posterior leaflet meets kind of between the ventricular myocardium and the left atrial wall. We see an example of pseudomad. So again, here you can see relatively clearly, although again, difficult. The annulus is clearly not here because you can see that the valve leaflet actually comes in a little bit compared to the left atrial wall. And we can see on MR, it becomes much clearer that the leaflet forms the pattern here. And in fact, the annulus is in the right spot and not just laced out to here, as you might say if you didn't notice that the leaflet was so curled. And here we see an example of true mitral annular disjunction, where the annulus typically should be right here, where my cursor is now, and the annulus has been displaced all the way up to here. And we can see that the leaflet meets in plane with that in all of these examples, but the top of the ventricular myocardium, which is where the mitral annulus should be, is actually down here. And so again, very hard to tell on echo, but this is an example of a patient that has mitral valve prolapse and mitral annular disjunction. If you spend some time looking at it, you can see as the mitral valve leaflet, the posterior leaflet, meets the plane at the tip of the ventricular myocardium. In diastole, it's sitting quite nicely, but then in systole, as the ventricular myocardium contracts, it's actually pushing the annulus up the wall into the left atrium a little bit. As I said, especially with how choppy it is, it's probably quite difficult to see, but it'll become much clearer when you look on cardiac MRI, and hopefully this plays a little bit nicer. But we can see that there's real swinging of the mitral annulus every time with systole, that it's moving significantly and it's displaced quite into the left atrium every time there's a contraction. Okay, so as you said earlier, it's a relatively common finding, somewhere between 1/3 and 2/3 in patients who have mitral valve prolapse, but it's been described in lots of, quote unquote, normal hearts or those without mitral valve prolapse as well. Some have described it as just a normal anatomical variation of the mitral valve annulus. But there's been relatively limited studies and no real RCTs as to what this means. But there's some significant consequences clinically associated with mitral annular disjunction. So although we said it appears that it might be a normal finding, maybe it's dependent on the extent of the disjunction. So like, is 10 millimeters of disjunction worse than 2 millimeters of disjunction? That might be important, and that might be what causes some of the complications. And then the complications are that it's frequently associated with arrhythmias, and most commonly ventricular arrhythmias, and also sudden cardiac death. And that's both with and without mitral valve prolapse. And there's a couple studies that have looked at this, as well as a physician paper actually that just came out recently that I'll touch on in a second. And mitral annular disjunction on its own has also shown to cause some LV remodeling. So you get an increase in the left ventricular size in excess of what you would see just with degenerative mitral valve disease. So even myxomatous mitral valve disease, we know, can cause some changes to the left ventricle, but mitral annular disjunction causes even more changes on top of that, or irrespective of the changes you would get from myxomatous disease. And some of the potential explanations for that are that it's due to either atrophy of the left ventricle or fibrosis as a consequence of annular detachment. Again, quite opposite theories, but two that have been described. And they can be quite significant, the arrhythmias. So if you have a combination of mitral valve prolapse, whether you have mitral annular disjunction or not, with frequent complex ventricular arrhythmias in the absence of anything else to cause the arrhythmias, we call that arrhythmic mitral valve prolapse. It's more common with patients who have very severe myxomatous degeneration or severe Barlow's disease with multi-segment MVP, but it's also more common in patients with MVP who have disjunction. And I said it's possible that this is due to LV fibrosis, potentially because there's a lot of traction. So as the annular disjunction is moving between the ventricular myocardium and the left atrium, that traction may potentially cause LV fibrosis and lead to an abnormal sequence or pathway for electrical conduction to then cause the arrhythmias. So patients that have mitral valve prolapse or flail leaflet or significant mitral regurgitation in general have a 2 times higher likelihood of sudden cardiac death versus the general population. And that's even in those patients who have no symptoms or no left ventricular dysfunction. Bileaflet prolapse in itself is not independently a trigger for sudden cardiac death. But mitral annular disjunction with mitral valve prolapse is independently linked to the development of ventricular arrhythmias, whether it be at diagnosis of the MVP or on follow-up. They are more likely to get arrhythmias if they have disjunction. But it's unclear about the correlation between the length of MAD, or how much displacement there is at that junction, and how many ventricular arrhythmias we get. So this is just an example of a patient that actually had sudden cardiac death. So it was a patient with known mitral valve prolapse and mitral annular disjunction, came in with a VFib arrest, and was found to have obviously significant disjunction of the mitral annulus on cardiac MRI after the fact. And they had severe myxomatous degeneration of the mitral valve and Barlow's disease. So again, just an example that it is something that quite frequently can happen. But the explanation is still relatively unclear. So we don't know if it's the prolapse itself that can cause sudden cardiac death and the ventricular arrhythmias. We don't know if it's the presence of the mitral annular disjunction with prolapse that can cause it. Maybe there's a component of both. As I mentioned before, we have had descriptions of disjunction in the absence of mitral valve prolapse. So it's possible that those patients are also at high risk of ventricular arrhythmias. And we do know that this was actually a study that was done, published in JACC in 2018, that looked at all these patients that have mitral annular disjunction, either with mitral valve prolapse or in the absence of mitral valve prolapse. And those that had MVP, approximately 7% of them had ventricular arrhythmias. And these, again, are all patients that have mitral annular disjunction. But in a group of patients that don't have mitral valve prolapse, they actually found that the prevalence of ventricular arrhythmias was significantly higher. So there's actually 31% of those patients had arrhythmias compared to 7% of the patients with mitral valve prolapse. So this might suggest that actually it's the disjunction part that puts you at risk, and maybe actually the presence of mitral valve prolapse doesn't really matter, and it's only the patients that have the mitral annular disjunction that are getting these arrhythmias. Another figure recently published at the ESC here shows kind of the presence of ventricular arrhythmias in MAD, but its association with mortality. So we know that patients who have mitral annular disjunction actually don't have excess mortality compared to the general population. However, we also know that when patients are followed over the course of years, they do tend to get more ventricular arrhythmias. So this one is looking at, this axis is freedom from arrhythmic events. So as this falls, that means that they're getting more ventricular arrhythmias. And patients that have disjunction in the blue here, we're found that over time they have more arrhythmias than patients with no mitral annular disjunction. Although, again, so far there's been no changes in the mortality associated with that. But it is important for follow-up and what you do when you see these patients and whether or not they're considered for primary prevention, like ICDs or devices. And then the last figure here is showing that when patients actually have ventricular arrhythmias, there is excess mortality associated with them. And this is in a group of patients that actually had mitral valve prolapse. So obviously, the more severe the arrhythmia, the more significant the mortality associated with it, which is what we see in this figure. So very lastly, I'm just going to briefly touch on why mitral annular disjunction might increase the risk for ventricular arrhythmias. And I've talked on it very briefly, but as we've said, the annulus portion of the posterior leaflet is implanted into the ventricular myocardium, and it supports the base of the leaflet and the fibrous end of the left atrial wall. So that allows that there's electrical isolation. So there's actually isolation of the electrical signal from the atrium to the ventricle in that part of the wall. We also know that MAD likely increases or progresses with age. And this progressive detachment, so as it's stretching more and more, may lead to periannular inflammation. And so inflammation in that area may lead to fibrosis. And that fibrosis in itself may lead to either an abnormal conduction pathway or create a sense of a foci, basically, for ventricular arrhythmias. And that might be a potential explanation for why that occurs. All right, so that is the end. So we briefly touched on what the normal anatomy of the mitral valve looks like. We talked about some of the causes and appearance of myxomatous degeneration of the mitral valve, the definition of mitral valve prolapse, its causes and criteria, as well as a good chunk on mitral annular disjunction, what it looks like on echo and MRI, and some of its potential complications. So thank you very much, and I'm happy if there's any questions.
So thank you, Ryan, for this very comprehensive review of this topic. We haven't talked about this for quite some time. So just mentioning of ESC, I was just there in Amsterdam, and it was attended by about 30,000 people. So it's I call this the rock concert for the cardiology. Speaking of this MAD situation, it's not infrequently that sometimes we run into patients, especially young ones, with MAD and VT. How cautious should we be? And if we do find that they have VT, how much is the burden that we get to be very concerned? And what should we do? Should we, refer them all to EP? Should we treat them with antiarrhythmic? Should we put ICD in all of them? What should we do?
Yeah, so there was I didn't want to get into it too much today, but there was a statement that came out just kind of a couple of weeks ago on August 10th, and some of the data that I presented here was from that. And they put out kind of a position on how to treat these patients. It seems like it's still unclear exactly who would benefit from an ICD, aside from kind of just our normal standards. So obviously someone who's had sudden cardiac death secondary to ventricular arrhythmia should get an ICD. Patients who have malignant arrhythmias, then potentially it should be used as kind of secondary prophylaxis. There's not enough evidence yet to suggest primary prophylaxis in these patients that have mitral annular disjunction unless they've suffered from significant events. And so they haven't really had too much guidance specifically into this population, aside from what we would do normally for patients who have VT, or again, secondary prevention in patients with sudden cardiac death. But I think they're kind of more studies are undergoing, and they're moving in the direction that there may be a benefit for some primary prevention, but they haven't quite said that yet.
Thank you. Yeah, I find this very, very challenging topic, actually. And I do have a young lady who has this problem, and she was really scared because of all the discussion that she heard from her physician, and that she was told that basically like she would die suddenly because of this. So then it actually make her anxiety much, much worse. So anyway, any other questions from my colleagues?
So I have a question, Qiming. It's Bob.
Go ahead.
So Ryan, for the dysplasia, I'm not sure if you said it, or for the difference between Barlow's and dysplasia, you've made that clear. How does mitral annular disjunction relate to Barlow's versus the dysplasia issue?
So I think I think it's still a little bit unclear. I mean, we know that in patients that have kind of Barlow's disease or the myxomatous degeneration, they're more likely to develop mitral annular disjunction. But it's still unclear exactly why we see some patients that have the disjunction without evidence of myxomatous changes, without evidence of prolapse, without evidence of Barlow disease, but that's still present. So whether or not there's some, I suspect there's probably some genetic linkage to it, and there's probably something else going on there, whether it's thinning of the area around the annulus, or some fibrosis for some other causes. But I don't think it's quite clear exactly now as to why we would get like annular disjunction in patients who don't have myxomatous disease. I don't know if that quite answers the question.
Yeah, I mean, I think there's obviously they're different. So I just wondered about, prevalence one versus the other. Sort of follow-up question then is, we send many of these patients with severe regurgitation, symptomatic regurgitation for surgery, and they commonly get repairs. What do we do with somebody who has mitral annular disjunction who we're sending for repair? What is this? I mean, I'm not aware that the surgeons do anything differently, but just maybe some do. I don't know if there's anything in the literature about that.
Yeah, I didn't quite come across anything. It was something I was thinking about as well. And there's been some people who have suggested that maybe in patients with mitral annular disjunction, there might be a benefit for actual replacement as opposed to repair, because repairing, you're not actually changing the plane of the annulus really, although potentially anchoring it a little bit more, there's still the potential for the sliding of the annulus a little bit. And so actual repair might anchor it a little bit better. There haven't been any studies that actually test that hypothesis, but it has been mentioned in a couple places. And then just kind of back to the first point you said there as well, the other thing I wanted to bring up where you said that, we do see this occasionally or kind of look for it, but I think part of the problem with knowing the prevalence and what the prognosis of patients that have this are going to be are that sometimes it's quite hard for it to actually be seen on echo. And so we look for it. We can see prolapse for sure, but disjunction is a lot more difficult and maybe it doesn't get called as often. And it's usually actually after referral from electrophysiology that they've shown that we've seen more of it. So patients come in with arrhythmias, they get seen by EP, maybe they get a cardiac MRI and then it's picked up. So maybe we're actually picking it up a little bit later. And so it's harder to actually say what the incidence or what the kind of outcomes of patients that have this and arrhythmias are when we're looking at it kind of post hoc.
Now, I find the diagnosis of MAD a little bit subjective, especially on the echo and over the years. And then we certainly underdiagnosed it. We don't call it as often as we should. Just to mention a few words about mitral valve prolapse, it is one of the first demonstration of the utility of having 3D echo. The original research actually came in the late 80s by Dr. Bob Levine at Mass General, who used a spark gap technology, which is an ultrasound sort of like emitting device attached to the probe that allows you to actually map the mitral valve. And he sort of published the first paper on the description of the saddle shape of the mitral valve. So that's an interesting historical piece. And also Leonardo da Vinci is credited as naming the mitral valve as the bishop head or bishop mitral. Some of the historical facts around this topic. Okay, any other questions? Okay, well, thank you so much for the review. It's really nice, and we'll certainly raise our suspicion for MAD moving forward and pay more attention to that.